We have about 100 questions, so I hope you've all had dinner. We should be finished by midnight. All right, Claire, what could be the cause of headaches in the temples, and what are the treatments or interventions available to address that?
Okay, so I would say if it's a headache in the temples, the first thing I would think about is a possible muscular headache or myofascial, referred myofascial pain. Oh, yes, Dr. Henderson's reminding me, it could also be TMJ type pain. So I would be looking at the musculoskeletal aspect rather than increased intracranial pressure for a temporal headache.
Okay, thank you. Is a question I might answer. How sensitive are X-rays for detecting cervical instability? And are there other options such as cervical spine CT scan if the upright MRI is not available? And you can detect flexion. You can detect instability of the craniocervical junction with a plain X-ray sometimes. The upright MRI is much more sensitive, but unfortunately, as you all know, it's not available in most cities. We have about 5 of them around Washington, D.C. for some reason. But if you can't get a upright flexion extension MRI, you can get a flexion extension CT in the supine position with a pillow under your head for flexion and a pillow under your upper back for extension. And that would give you a rough, less sensitive estimate of instability. You can do the same thing with a supine MRI with a pillow under the head for flexion and a pillow under the shoulders for extension. So there are several options. But if you only have a flexion extension X-ray, I know I can get a rough idea if there's instability, and people like Miles Kobe, the neuroradiologist, and other skilled neuroradiologists who are used to EDS can estimate whether there's craniocervical instability. All right, so let's see. Patricia, what could cause chronic neck pain that feels like it's pulling forward and down, accompanied by a grinding sound when the neck is cracked, even if the X-rays show everything is normal?
That's very specific.
When standing on the left foot, looking to the right. Yeah.
Well, the pulling of the head forward can actually be quite a few things, and I'm so glad that we have our oral myofunctional therapists that have been presenting, because there is fascia within that space that can actually start to pull the head forward into that position. Poor posture just over the years as well, or instability that can get into that feedback loop can tighten up those sternocleidomastoids in the front of the neck there and start to pull forward more. And also when we have upper cervical instability, it can start to affect the cranial nerves, which innervate those muscles as well. So that can all feed back into that chicken or the egg story of why the head is being pulled forward. And then if you have alignment issues, you can certainly have crepitus and grinding when you are moving or trying to adjust because it's not in the correct position. Was that all of the pieces?
Thank you. Very good. Susan, with abdominal vascular compression, such as the Nutcracker syndrome, superior mesenteric artery syndrome, or the May-Thurner syndrome, are there some movements and core exercises so painful they can lead to fainting? And what can you do to avoid that?
As far as treatment, so Patty's probably the one to answer this better than myself, but really, again, being in proper alignment, spinal alignment, and working on, core stabilization, using the deep stabilizers to support that alignment, and again, that's going to decrease the amount of compression, it can be on those structures. But Patty, you talk a little more from there.
Yeah, and we'll actually be talking about this on Saturday. A colleague and myself spent the past year pulling people into clinic and looking at median arcuate ligament syndrome, or this celiac complex compression that's happening in that space, and what's happening around everything from head to toe. So we have not 20 minutes worth of information, but we will do it just to at least brush the surface of what we found. There's so many things that you actually can do for vascular compression from a physical therapy, manual therapy point of view. So I don't think that we've ever really discussed that before. And my colleague is on the other side of the country, and I couldn't find anybody in between. That's how rare that we talk about it. But yes, you can have, especially in this area here, you have the whole celiac complex. We have your celiac nerves as well. You have a whole autonomic bundle there, and it can create a very intense pain response in that area. So I'm excited to present again in 2 days on specifically that. So whoever had asked that, I'm hoping you'll tune in.
Thank you. Eloise, can you address when you would use craniosacral therapy versus manipulative osteopathy?
Well, first, I'm not an osteopath, but craniosacral therapy and manual osteopathy are similar in that craniosacral therapy is the grandchild of that. So in craniosacral therapy, we do talk about indirect and direct technique, but craniosacral therapy in and of itself is mostly indirect, where osteopathic and chiropractic and even massage therapy is more direct technique. So there is a technique being done to the body to come to a resolution actively, where in craniosacral therapy, it's indirect. We allow the body to take us into its own unwinding, unlatching organization. Did that answer the question?
Yes.
Good. I hope. Let me know if I didn't.
Very good. John, can you clarify the levels of instability in the cervical spine? Is it always the top of the cervical spine, or do you see a lot more in the subaxial lower spine?
I'm actually not sure. I should have started this. I'm not a clinician, so I'm not actually doing any work. I'm just handling the data from the outcomes that we're seeing. So that's something that I think Paulo that's best to answer.
All right, well, I'll take a stab at that then. In the EDS population, I think the most common thing we see is atlantoaxial instability. And then that's probably followed equally by craniocervical instability and mid-cervical instability, especially C4-5. Mm-hmm. In the non-EDS population, C5-6, C6-7 are more common, but in EDS, C4-5 is probably the most common unstable cervical level after atlantoaxial instability. Susan and Patricia, if medical help for upper cervical instability is unavailable in my country, what can be done to alleviate fatigue, dizziness, and headaches caused by those conditions?
Well, that's a tough answer, because I would say find somebody who does telehealth, because there are some that can do across state and country lines as a consultation, but I hesitate because Susan and I do that and nobody can get in to see us. So hopefully, in spreading the word on how to treat patients with the condition, it will start to spread throughout other countries. In the US, we finally just got accepted to talk about upper cervical instability at the American Physical Therapy Association just this year. So it's very slow movement, but it's happening.
We're getting there. And real quick, I wanted to add, probably one of the most important things is back to the current level of function and awareness and mindfulness of being in proper alignment. So yes, it has to be taught properly. I'm going to have a patient education program online that's going to be out soon, just with my methodology. So I think that will help, just because we have both of us, such a wait list. That'll help so that the patient can start on their own and start to do the work ahead of time, so that by the time if they do need to get in to see us, then we can work from there as far as the physical therapy aspect of it all.
And knowing it's problematic, I'm also part of the newly launched educational platform as well. That it's a monthly one, so we don't have everything up yet, but through Stripe Solutions, we're going to be putting up these cervical exercises and things like that, the eye muscle energy techniques, so a lot more specific to a diagnosis rather than just general movement.
We're getting there.
We are. We're trying.
It's taking time.
Claire, has there been any research into the potential connection between EDS and functional neurological disorders? And by that, I assume they mean dystonias. And if so, where can they find that information?
So this is a topic that's been under a lot of discussion at some of the recent ECHO sessions, our drop-in session recently on the EDS program. We've talked a lot about functional neurologic disorders. The dystonias, I don't know of any published research out there connecting the neurologic complications of EDS with dystonias and specific proportions or percentages of people that are manifesting those, but we certainly see them. I mean, the patients, I've had so many patients who've had dystonic reactions that seem to be related to upper cervical instability, and also there's a mast cell connection that's related to these dystonias that's very interesting and kind of perplexing to me. Mm-hmm. So it's an area that requires a lot more investigation, but in my clinical impression, just from the patients that I've seen, I really do believe there is a connection.
I know Cohen and Chang put out a good review article on what I was calling the triad, EDS, POTS, and MCAD as canonical benchmarks for musculoskeletal dysfunction, dysautonomia, and immune. So yeah, I think it was Cohen and Chang. If you look up those two authors, it's a really good article.
Thank you.
I think I see dystonias in about 1 in 3 patients, and we usually try to treat them with Valium on trihexyphenidyl, and more recently with the L-dopa carbidopa, which is Sinemet used for Parkinson's. And Professor Hominy in France has used that on over 500 patients. Well, and I've found it very satisfactory with many patients. If they don't work, then I add lacosamide, a anti-epileptic, and that usually, the combination gets about 90% of patients. Susan, are there any non-surgical treatments for tethered cord or Chiari malformation? In 5 words or less.
Conservative care, conservative treatment. Again, it's what you do with your body. So if you think about your neurological system being your electrical system, you're a machine. And when you've got hypermobility and you're stretching, compressing your electrical system, what's it going to do? Over time, it's going to break it down. So again, alignment, get the compression off the nervous system, physical therapy, being mindful, being aware of proper alignment in everything that you do. And the more you practice it, the more it becomes, your overall normal. Yes, we're always going to have to be on heightened awareness and mindfulness. There's no fix for this, but you have to be diligent and you have to do your job as, I'm one of us. As a patient, and you really have to take it on and apply it to your everyday. Catch yourself, make that change. We're never going to be perfect. We're always going to be falling into bad postures through fatigue and our active system. So, yeah. So that's going to help us decrease the amount of signs and symptoms that we're going to see overall with these patients, the more that we can get them to do it. The problem that we have are some of these patients, do come in, and I have it in my clinic, Patty does too, other PTs, they come in, they want us to fix them. They're the ones that will probably jump to surgery right away as opposed to putting the work into it, because these, I see a lot of severe patients, just like Dr. Henderson, a lot of dystonia patients. They've got to put the work in. I mean, some of these patients, they're being seen 3, 4, and 5 years, and we're taking them from a severe bedbound, status all the way to now they're working again, or they're repairing again, and that takes time. It takes work. So.
Thank you. This for everyone. For those who have some degree of craniocervical instability but are discouraged from having the surgery, what are your opinions about PRP injections?
I do have a lot of patients that get them done. I think it's a great tool. I think there are so many great tools out there, but to think one thing will be curative for any condition is not the best way to look at it. I typically, with my patients, I live in an area where we have somebody that does great PRP and prolotherapy injections and does the pickle, the PICL for ligaments that other people don't get to. So I do see a lot of these patients, and there are so many other things to work on other than just PRP or prolotherapy. And I think if we're down to the point where you feel like you have a specific joint problem that a regenerative medicine would help, and we're not hyper-responsive and hyper-reactive to manual therapies, we've calmed down the nervous system, we've calmed down the systemic inflammation, those patients actually have very good results. It, again, depends on the individual, and it depends on who's doing the injections as well and how much experience they have. But it's still just one tool. It's one tool.
It's a very expensive tool. So again, you have to go back and protect your investment. So it's about doing the work too to protect that. Otherwise, you're going to be back in there getting more and more PRP and Prolo and stem cell. So
There's also the risk of generating more scar tissue at the area and at the upper cervical spine and exacerbating the problem, the neurologic problems that are related to the craniocervical instability. So it's not a panacea by any means.
Eloise, how does one find a craniosacral therapist? And would you recommend it for OC2 fusions, following OC2 fusions? And by OC2 fusion, I mean a craniovertebral fusion stabilization.
I usually recommend people go to the upledger.com website to try and find a craniosacral therapist. There's a find a therapist button, and you can look in your region for somebody. But like all fields of healthcare, sometimes it can be hard to find somebody who has extensive knowledge in Ehlers-Danlos syndrome. And there has to be a good fit for you and that therapist. So if you happen to find somebody who you really like, who has limited knowledge in EDS, I'm always available to at least bounce things off of. I'm happy to talk to anybody. As far as any fusion goes, craniosacral therapy is okay. It's okay to do as long as we don't have any strong traction techniques in our therapy. So our therapists have been trained how to adapt craniosacral therapy around any fusion. Usually safe.
Thank you. John, do you ever see any complications after craniocervical fusions? And also, do you have any recommendations for people who are still having pain in the back of the head more than several months after surgery?
Yeah, there have been a few complications. Wound reinfection is probably the most common one that we see. And as well as increased pain, pain that prolongs. As to the treatment for that, I'm not a clinician, so I have no recommendations for that either way. Perhaps you do. Anyone here?
What are your recommendations for postoperative pain in the back of the head?
A standard physical therapist might be able to help with muscle tension and things like that. The more I got into EDS, the more I strayed actually from standard therapy, and I do cranial sacral therapy, which might be appropriate. I do neural manipulation, which would very much be appropriate in that case as well. And then there is actually brain manipulation too that people can be trained in. So if we can find a specialist that works in those areas, those might be great spots to work on. I just don't think a lot of people realize that there are some therapists that are trained in other techniques.
Great, thank you. Claire, is there any association between Ehlers-Danlos syndrome and numbness and tingling of the hands and feet?
Well, there are a lot of the neurologic complications of Ehlers-Danlos syndrome that can result in numbness and tingling in the hands and feet. The small fiber neuropathy that can be a complication, and some of these instability syndromes, if we have instability either at the craniocervical junction or at the C1-2, that can result in paresthesias in all four extremities because all the nerves that go to the whole body come through that opening at the base of the spine. I mean, at the base of the skull. So, yeah, I mean, there are a lot of potential causes of paresthesias in the hands and feet that could be related to EDS complications.
Right. I think in my experience, many patients with atlantoaxial instability have intermittent numbness of the hands or body, but they're intermittent as opposed to, say, degenerative radiculopathy where the numbness is more persistent. So, but we also have to keep in mind thoracic outlet syndrome, where, especially when patients start bending their shoulders forward, they can exacerbate numbness and tingling. And, right, Susan, what could cause dizziness and neck pain when looking upwards? It goes away as soon as the head returns to a neutral position. And what techniques can be used to find a balance?
So again, upper cervical instability, can do that. Absolutely. In fact, I just wrote up a case series report, and that was, we did the upright MRI and an extension. It completely relieved his symptoms. I mean, so once again, it's, the instability is still there. It's about strengthening the support system. So your support system is your muscle system. So, you got your bones, you have your ligaments, you've got your electrical system running through it. So you have to build that strong support system at the deep stabilizer level. And the deep stabilizer level is the engagement of postural alignment of the muscles closest around the spine. But then you've got to teach your superficial muscles to be good backup stabilizers to also protect. So again, he recovered and returned to, 100% function almost, but he still goes into flares, mild flares, but very managed after years and years of therapy and doing a great job. But again, it's about still managing that instability long term. It's there for a lifetime unless they're fused, so.
All right, Patricia, you get the last question. What are your thoughts on thoughts on using cervical traction in Ehlers-Danlos syndrome patients? And is that contraindicated with craniocervical instability?
What a great question. It was like you were in our international meetings discussing this very thing. I think it really depends on the therapist and their hands. When I do cervical traction, if you want to call it that, I can do it between segments, and it's very different from what we think of in standard therapy of pulling the head off of the spine. So it really depends on the individual. There's very, very light touch that can be very therapeutic, and when we get down into the more mild cases, they might actually have some relief with with a lighter or a more gentle pull, and we typically call it subtherapeutic, which is for most heads about 8 pounds or less. But if we're starting to get into higher pulls and we know that there's laxity, we don't necessarily want to continue to pull and separate on those ligaments that aren't holding the hand there in the first place.
Brilliant. Well, you've all been absolutely brilliant. Thank you very much for your talks.
Thank you.